Thank the scientific committee for giving us the opportunity to present our results here. So I'll skip the introduction. I just want to say that although these tumors are diverse in its histology, ages and locations, we are still treating all the same way. So in the recent years we have learned that most of the low-grade gliomas have the RAS-MAC pathway altered, and the most frequently alterations are in the BRAF gene, but we still don't know exactly what these alterations mean in the clinical setting. So we focus on the B600E point mutation. We previously showed that those low-grade gliomas that transform in high-grade gliomas have a high incidence of this mutation. So we wanted to know the real incidence of this mutation in low-grade gliomas. We wanted to know the outcome of these patients, and we also wanted to know the response to conventional chemotherapy and radiation and even surgery of this subgroup of tumors. We went to the CKID score, and what's important in this score is not only the big numbers, but also that patients that are normally diagnosed at Toronto, they stay in Toronto. So we have a long follow-up, so we don't have the referral bias. So now we have more than 500 patients with the B600E mutation status known. We detect the mutation mostly by ddPCR, which is a very sensitive tool to detect this mutation, and in those patients who didn't have DNA, we used immunohistochemistry. I wanted to say that we have a poster with very good results in specificity and sensitivity in immunohistochemistry, and this means that we can use this technique in almost every country to detect this mutation. We knew that we needed a good denominator to talk about real incidence, so we really pushed to have all the tumors from 2000 to have the B600E mutation tested, and we succeed. We have 92% of the tumors done. So our findings are that this mutation is found in a higher incidence than we expected. So 17% of our patients had the mutation. We found also that we can find almost in any location, but what's more important is that more than 32% of the mutated patients were in the midline. And as we know, sometimes we don't biopsy these patients. And if we don't biopsy them, we will not know the biology of these tumors. We knew we were going to find a high incidence in PXA and ganglioma, but we found also a high incidence in diffuse astrocytoma and other low-grade astrocytomas. Although numbers are small, this slide shows you that we can find the mutation in almost any histological subtype. Then we went to our whole cohort of more than 500 patients to study the outcome. And as you can see in this slide, we found that the patients with the mutation have a poorer progression-free survival, and not only progression-free survival, but also overall survival. And as you can see, these patients progress several times, and they have late deaths 8, 10, and 15 years after diagnosis. So then we wanted to know why these patients have this poor survival. And we studied the surgery, the response to chemo, and the response to radiation. Of course, extent of resection is important, and if you don't get a gross total resection, your progression-free survival is poorer. But we found also that those patients, even with gross total resection, some of them progressed, which is important because we have to follow these patients very carefully. We know that progression-free survival after the first line of chemotherapy in low-grade gliomas is around 45 to 50%. So in the B600E mutated patients, the progression after chemotherapy was high, 25% of progression-free survival. And we also know that after radiation, low-grade gliomas normally respond better. So in this population, the progression-free survival after radiation was only 42 and 28, 5 and 10 years later. We then studied secondary mutations. And why CDKN2A? Because we know it's a secondary hit in many tumors, and also because we previously showed that those patients with low-grade glioma that transformed to high-grade glioma had a high incidence of CDKN2A deletions. So first we studied the patients without the mutation, and as you can see, CDKN2A didn't show any difference, but was in those patients with the mutation where CDKN2A deletion is stratified into two groups, a very, very high-risk group and a high-risk group. In summary, in this regression model, you can see that those patients B600E mutated with the CDKN2A deletion and not gross totally resected, a very progression-free survival and also a very poor overall survival. And remember, we are talking about low-grade gliomas. So we define a very high-risk group in low-grade gliomas. And we think these patients need some new therapies up front. So to confirm our results in the B600E mutated patients, we collected an international validation cohort in North America, Europe, and Hong Kong. We have more than 140 patients with very similar characteristics as in our CKIDS cohort. And we found that in these patients, progression-free survival and overall survival was also poor. That extent of resection was also very important, confirming that even with a gross total resection, some patients progressed, and that CDKN2A status also stratified the tumors in two groups, a very high-risk group and a high-risk group. And why this is important? Because as you know, we now have targeted therapies. We are waiting for the clinical trial in pediatric patients with the B600E inhibitors, but we know with several cases in the literature and also with patients that we have treated with compassionate use, that these patients are responding well to these inhibitors. So we went then to the MRIs of the patients treated with chemotherapy at diagnosis and 6 months after starting chemotherapy. And as you can see, those patients in the CKIDS course and the validation course, most of the patients didn't respond to chemotherapy. I added 5 patients, it's only 5 patients, treated as compassionate use with B600E inhibitors, which all respond to chemotherapy. We can see it better in this slide, where in the right side you can see the percentage of patients that progress 6 months after chemotherapy, and these percentages are high for low-grade gliomas. And on the left side you can see the response to chemotherapy of the first line, not too bad, after second and third line. And of course, only 5 patients, but all responded to targeted therapy. So, our conclusions are that we found a high incidence of this mutation in low-grade gliomas. Also that this mutation classifies an aggressive subtype of low-grade glioma resulting in poor progression-free survival and overall survival. This group shows a poor response to chemotherapy, conventional chemotherapy, and radiation. That secondary mutations like CDKN2A can help us to stratify these tumors, and that BRAF mutated tumors may respond better to targeted therapy. So we started in the 30s with surgery, which is still the main treatment in low-grade gliomas. We then in the 70s and 80s used radiation in those patients that were unresectable, which now we try to avoid because of the secondary effects. Then in the 90s, we started with chemotherapy, which is now the standard of care treatment in these patients. And now in 2016, should we move to targeted therapies? Should we biopsy upfront all these patients to know the biology? I just want to finish to thank the Pediatric Low-Grade Glioma Task Force, led by Uri Tabori, Cynthia Hawkins, and Eric Buffet, and also all the colleagues that collaborated in the validation court. Thank you very much.